Tebampa bangamba jenjaga teriiwo.
Ne bandagira nzireyo oluvannyuma lw'omwezi mulamba.
They told me to go back after 2 weeks.
Nagenda mu ddwaliro emirundi ng'esatu nga wenzira ewaka.
The pills were out of stock.
Nakagenda emirundi 6 ne sifuna ddagala.
The injections, the pills, the implants, they had nothing.
Nadda waka era sobola okubeera n'omwami wange nenfuna olubuto.
Nenfuna olubuto era nenva mu ssomero.
Kayate nenzaala abaana nga sibeeyagalidde naye nga sirina kyakola.
Singa abakyala bali bagenze mu malwaliro nga family planning gyeziri ne bazifuna,
baali badde balina obulamu bungi ate n'abaana baali badde kwegamba. Baali badde basobola okuvaayo ne beekubira omulanga.
Today I've been meeting some of the women I represent in this community. I've been speaking to them about maternal health, about safe motherhood, family planning and contraceptives. I've also been listening to their stories.
Mukama alinga yandabula nti weeyunge ku family planning era nayambibwa nnyo kubanga nali ntuuse mu baana 5. Naye singa nazaala bangi nandimenyese nnyo ate nga sikyalina maanyi.
Tuyambi buyambi ne batusembereza ku family planning wali ku ddwaliro ne tubeera nga tukola ki. Kale bw'oba webbye n'owebba mangu n'ogendako wali okusinga ogenda emitiyana. Transport yasingira ddala.
When I asked whether they have ever known about a woman who died in pregnancy or childbirth, they all put up their hands. So each one of us here in this community, as we grow up, we see it. The use of contraceptives can considerably reduce maternal mortality if every woman who wants to contracept has access. Because contraceptives will prevent unwanted pregnancies. The fewer pregnancies you have, the less abortions. And you know that abortion accounts for a big percentage of maternal mortality. But then when they go to, there's a center nearby here, they can't find the methods they would want to use.
All these mothers here are all family planning mothers. They have come to attend family planning clinic. Some have so many children. Some feel they don't even have money to cater for those children. They deliver year by year, year by year. You find that malnutrition is in the family just because of not spacing those children. So that's why they want to start family planning. Though the problem we have, that some come when they want certain method, and some of those methods are not available here. Like we now only have pills and depot, so we don't have normal plants, we don't have IUDs, we don't have condoms, female condoms, implants. So many women come and then ask for those methods which we don't have. I feel bad and very challenged because when I have the knowledge and I have the skills, but I don't have the method.
Contraceptives come in the country and they're stored at national medical stores. There's a lot of paperwork when orders come in, which leads to delay. And the schedule is bi-monthly delivery of these contraceptives. So you find that national medical stores may take 4 months to deliver on the first order, and hence having a backlog. But the good news is that national medical stores is working towards having the whole system automated and electronically managed. And that is going to shorten the lead time for delivery and ordering of contraceptives. Now, once that level at national level is finished, the last mile is a big problem because districts don't budget for distribution of commodities. So when they receive the commodities from the national medical stores, they may even stay in the district store for even a month when actually facilities are stocked out. The district should be able to budget so that when they arrive, on the same day or the following day, they're able to distribute those commodities to the health units. In one day, Coca-Cola can transport the Coca-Cola products and people drink in the villages. Why don't we do it in one day for a woman to be able to access contraceptives?
5 years ago, issues of reproductive health, issues of family planning, maternal health, didn't appear much in parliamentary debates. But today, you know, we've managed to bring maternal health issues on the legislative agenda, and government has created a budget line for commodities, for reproductive health commodities. You know, it gives us a basis to advocate for more.
Right now in Uganda, 95% of the funding for commodities, contraceptives, is from donors, 5% from the government. We also need the government to increase its commitment gradually. We would like to see a reverse, where the donors are coming in to fill the gap, rather than the government coming in to fill the gap. The government has that responsibility.
Everybody has a role to play. The government, which provides resources, someone who makes orders, someone who is responsible to transport the commodities from national medical stores to the delivery point. Then at the district, from the district to health centers, civil society, public officers, health workers must all become champions. When people are aware of their rights, when people can demand for services, when people can put pressure on the government, when parliament can task the ministers, that is positive. And if we could push this movement further, everybody has a role to play.